Compared to Alzheimer's disease, which is the main differential diagnosis when it comes to dementia with Lewy bodies, you really need to make a much more thorough assessment, because you need to elicit all these additional features which are typical for dementia with Lewy bodies, which are not present in Alzheimer's disease. Because in both conditions people have cognitive impairment, they have dementia. But the patients with dementia with Lewy bodies, they have additional features which if you don't ask, you will not know about them. For instance, they have a sleep disorder, they have a REM sleep behavior disorder, which if you don't ask the spouse, have you observed that the patient is acting out their dreams, that they're moving around, talking while they're asleep? It's quite rare that the spouse would actually volunteer this sort of information, because for them it doesn't seem to be at all related to the problem the patient has. And the same thing you have to ask about, do they have difficulties, have they slowed down walking, have they had a lot of recent falls, have they had some near falls? And people don't volunteer this information. To us, we think visual hallucination, this is all very clear, but to the patient themselves, they clearly don't say, I have visual hallucinations. They describe maybe people living in their house and they're convinced they live there. So for them, this is nothing abnormal. Why would they tell you that they have these people living in a house? So again, very frequently you get the information from the informant who will say they're talking about seeing people in a house, seeing animals in a house. At times they get terribly distressed about these visions, but at other times they might be quite happy with them. So it's the whole, you really need sufficient time to talk to the patient, to talk to the relative, but also you need to examine the patient. And certainly in UK, not all patients, when they go for their memory clinic assessment, have a physical examination. And this means that if you don't do a physical examination, you won't notice that you won't do a blood pressure, standing and sitting, so you will miss the postural drop, which is the sort of little cue towards the dementia, but you won't do a neurological examination, which is totally essential to pick up some very subtle Parkinsonian symptoms, because we're not talking about Parkinson's disease, where the patients have very clear-cut, prominent Parkinsonian symptoms, certainly in the more advanced disease. We're talking about really looking for subtle neurological symptoms and signs. The difficulties is if you give a wrong diagnosis, that the expectations of the family is totally different. So they're not aware what can happen. So they find it much more distressing when the patients have symptoms like hallucinations, if they fluctuate from day to day, if they can't sort of plan what they're going to do, the next day. The other problem is that they frequently get treated with medication which perhaps is not most appropriate, so they get given neuroleptic medication which makes the patient much worse. If you give a misdiagnosis, you also don't really prepare them so well for the prognosis, because patients with dementia with Lewy bodies have a worse prognosis. They need more social services. And again, this is sort of very confusing for the family when they can't plan the future.